Release last night. There's probably going to be about 20 people that don't come. Don't worry about food or coffee. And we ran out of coffee, so that's a good sign. Again, my name's Jan Rutherford. I'm with 3T Systems. We're the folks putting on this event. We're really happy you're here, and we think we've got a great event. We're going to end right at 9 o'clock today, and what I'd like to do is welcome everybody, including our partners, and our partners are Aventura and AppSense, Citrix, NetApp, TW Telecom, and sponsored by Cisco, and the Cisco rep is this young man right here, my friend. So
representing the entire company.
Yeah. So great breakfast, and thank again Mike and Cisco for sponsoring the event. We really appreciate it. And big kudos to Elise Mecchio in the back with the camera. Elise is the one that pestered you with all the phone calls and email and created this great turnout, so we couldn't have done it without her. And the 3T folks in the room, if I could ask you guys to stand up just so everybody knows who they are, including our CEO, Kieran Dwyer, and the whole gang. So if you haven't had a chance to meet some of the 3T folks, it'd be great if you could. And the thing I can't forget, because we kind of messed up at the table a little bit, I don't know, does anybody know what this is?
Yep.
What is it?
Bluetooth.
Yeah, Bluetooth-enabled speaker. It's called a jam box. It's really cool. It can actually pair with your phone and create like a conference call, or with your computer if you're doing presentations. We're giving this away today, raffle. Andrea back here has a bowl, so if you could get a business card out and drop it in there, she'll be walking around and throw it in. But we're doing that just as a way to say thanks for coming out. And if you haven't played with one of these, it's pretty good, and the sound's pretty good too. Let's see what else. So last time we met was June 6th. We were at the Oxford Hotel, and the forum was on gain practical perspectives from leaders in the healthcare continuum, executing healthcare strategies in an unpredictable future. And the first question we asked the panel is, what's right with healthcare? And luckily, we had Arlen Meyers there, Dr. Arlen Meyers, that stood in for somebody that was a no-show. And Arlen did a great job and actually helped us put together this panel. So I think the turnout has a lot to do with Arlen's influence, as my guess. So
thanks for moving me up to the A-list. Just fill it.
Yeah. Well, we appreciate you being here. So one of the things that we want to do a little differently than the Oxford is, I'm going to moderate and ask a whole bunch of questions, but we want you all to jump in at any point, because in the audience are 19 CEOs. So there's a lot of executive experience here, a lot of some great community leaders, and have lots of different perspectives, and that's what this is all about. So that's what we'd like you to do. We're also we've got some of the 3T folks are going to be on Twitter, hashtag 3T Healthcare. So if you want to participate or get somebody that's not here to kind of listen in on what we're doing, hashtag 3T Healthcare is the marker. And today our focus is on mobile health. And we came up with this. Arlen actually helped a lot with coming up with the topic. And we really want to talk about the convergence of healthcare, mobile health, and technology, and what it means for the healthcare ecosystem. So really that's our focus today. And one of the things I wanted to do is tell you what I pulled out of the news just yesterday. And tell me if you know who this quote is attributed to. We believe there are far superior ways to get back to a patient-centered healthcare system, the nucleus of which is the patient and her doctor, and not the government. We believe consumer-driven market-based reforms do more to alter the cost curve of healthcare inflation. Who do you think said that?
Romney.
Romney, close. Ryan. Yeah, just yesterday.
Lakewood.
Yeah. Another announcement yesterday. How many of you have heard of Patients Like Me? Really cool. Because when you're sick or injured, you want to talk to people that are going through the same thing you're going through. Merck just did a deal with Patients Like Me for psoriasis patients. They're creating a community, and they're going to get real-time feedback on what's going on with psoriasis patients. real easy to report their symptoms. It's not something like hypertension that's sort of asymptomatic. So that was just yesterday. Another announcement yesterday, baby boomers trust physicians' recommendations on medical apps. 60% of boomers are likely to download an app recommended by a physician to take care of their health, to look at weight, nutrition. The trick is, how do you get them to use the app once they download it? Another one was, how many of you have heard of Doximity? Yeah. So Doximity is basically social media, Facebook for physicians. Physicians are still sending 15 billion faxes a year. And Doximity is a way for physicians to talk, specialists like Dr. Meyers, to talk to referral partners and to collaborate in real time. And others have jumped in the fray. IBM, Oracle, SAP, Salesforce are all trying to figure out how to make email and faxes basically go away. So there's a lot going on. I mean, this is just yesterday, and what we call the ecosystem. So hopefully we'll have a really robust conversation today. And our panel, hopefully everybody had a chance to read the bios, and that's part of the reason that you're here today. You know, starting with Dr. Meyers, I don't even know how to read his bio because I'm convinced he doesn't sleep. So let me think. You're at CU as a professor of otolaryngology and engineering at the Bard Center, where we met on biotechnology and entrepreneurship. CEO of Society of Physician Entrepreneurs. We could just keep going. But
maybe it's best you move on,
yeah,
so that the introduction doesn't exceed the length of my comment.
Yeah. Well, one of the cool things that he's doing now is the CEO of Society of Physician Entrepreneurs, and Arlen's gotten involved in the Innovation Pavilion and Health Starts, and that's how I think we got introduced to Bob and Nim. So, and Bob and I have a connection way back to health grades, and what Bob is doing is working on helping hospitals and others aggregate all the data that's available on them from Newsweek or Health Grades or different places, and how do you position that? And kind of commuting back and forth between here and Newport Beach, rough life. Right. And Nim is a social entrepreneur. I think his perspective is going to be great because you haven't been tainted by being in healthcare your whole life. You actually started out with Arthur Anderson, looking at emerging companies and healthcare companies, and now you've got some interest in techs for health, and of course you're doing social entrepreneurship all over the world. So we're really glad to have you. And last but not least is Larry Gray from the Assist Group. And Larry, he looks like he's 35 years old, but he's been CEO of, I think you've been CEO of six companies?
Healthcare.
All healthcare companies, right. Mainly on the payer side, insurance, technology, and what Larry can do that a lot of us can't do is claim actual quantitative success with every venture he's been in. He's a turnaround guy, and the Assist Group is actually a client of 3T and just a phenomenal company looking at helping resolve and review catastrophic claims. So we've got a lot of different perspectives here from a mobile health perspective and what we call the healthcare ecosystem. So without further ado, one thing that we're doing at 3T is we're a complete IT services company. What we're focused on is mainly the healthcare market. That's probably 50–60% of our business. And what we're trying to do is consult with folks, provide managed services, and hosting, in the hopes that they can focus on their core competency. And in healthcare, that's taking care of patients. So I'd like to kind of just go down the line and ask you gentlemen, when you look at what you're trying to accomplish with your current ventures, what are the outcomes you're shooting for today, and how does that affect the entire healthcare ecosystem? So what your small part, and then how that plays into the big scheme of things. And Bob, if we could start with you.
Well, we're branching out into digital health in a couple different venues. Most of our acute care data has given us some expertise in big data applications. So we're now working with iTriage and Aetna and helping them manage their big data flowing from mobile devices, 2 million subscribers overall, 1 million iPhone, 1 million Android users. And what we're helping them do is understand how to localize behavioral patterns around individual use of those mobile devices. So if someone's flowing to an ER with a condition, has looked up a symptom, they get some, the ER has some indication of what's going on with those patients. Our goal is to help improve the outcome overall. So the hospital has an opportunity to market better outcomes in their local marketplace. That's one example of where we're going.
So my initiatives, I think, are going to be measured by two metrics. One are health metrics, and the other are health outcome metrics, and the other are economic development metrics. So on the one hand, all of the digital health initiatives and society and all that is really about cost, quality, access, population health as an outcome. Because right now, one of my concerns is there's too much concern about the inputs and not enough concern about the outputs. And the second holds true for the economic development pieces, which traditionally have to do with companies, patents, employees, taxes, startups, all that stuff. But I guess the headline that I would give you is we don't know the data, and we don't know whether any of the stuff we're going to talk about today makes a difference. So I guess my pitch to you is we tend to get wrapped up in the technology, we tend to get wrapped up in the enthusiasm, but the bottom line is unless we're really making a difference, we're just spinning wheels.
The explosion of high-dollar medical claims over the last 10 years is just astronomical. I won't go into all the data, but this is a trend that if you're in the reinsurance market, the health plan market, or have any risk over about $100,000 per patient, you're seeing it, and it's affecting you. We get those claims from all over the country. And our goal is to really become the national leader in what's happening with high-dollar claims, why are they occurring, and what can we do about it. So our vision is in the next 4 or 5 years that we will have the most complete database on what's going on with high-dollar claims and begin to impact the rise or try to reduce the rise of high-dollar claims by the data that we are gathering. Now, a lot of data out there, Milliman, Fair Health, you name it, there are a lot of folks who are tracking this data, but because we only look at high-dollar inpatient medical claims, we think we'll be able to slice and dice that data and begin to feed back information that will have an impact on those claims going forward.
So at Text for Health, what we're doing is we're pretty much leveraging the most ubiquitous form of communication on the planet, which is text messaging. It's often overlooked, especially here in developed markets. Everyone's land grab for apps, and you want to talk about how do we download these apps, but only 25% of apps that are downloaded are ever used after the first download. And so how do we, at Text for Health, we're looking at that communication platform, simple text messaging for patient education, patient awareness, starting with simple things like appointment reminders. 7% of all appointments are missed. Reminders if you're showing up for a surgery to not eat breakfast. You show up for a surgery, you've eaten breakfast, the whole thing's called off because it can't put you under. It's 10 grand loss for the hospital, right? Simple text message, 2 hours before the surgery, 6 a.m., telling you, remember, don't eat breakfast. So just, again, thinking about driving some behavioral change ultimately is what we're trying to do, but without having to drive behavioral change, right? So an app is behavioral change. Text messaging is not. Everybody text messages. So how can we leverage that everyday communication in the healthcare ecosystem?
I want to introduce some folks that are my guests. Ariel and Talia Schatz are here from Jerusalem. They heard about this meeting and they flew in for this meeting. That's not, I hope, I'd like that. It's actually not true. But thank you. But in the spirit of collaboration in the audience, Talia is a human behavior expert in bioscience and health. So I'm interested in your comment. We haven't even got started with this, but just kind of give us a few minutes on what you're doing.
So, hi everyone, I'm Talia. We're on chats. I'm a social psychologist, and most of what I do is medical decision making. Started just to give you an overview of why I started doing this. I was invited to teach genetic counselors on psychology. Maybe I'll come here because thank you. I'm just saying hi to see you now. Kind of nice. So I was invited to teach genetic counselors, and I said, I want to sit in on a genetic consultation. I had kids before I got into this profession. And I sat in on a consultation, and it was mind-blowing, because there was a genetic counselor on one side, knowledgeable, terrific, smart, and a couple that came in for consultation. They were deaf, they were albinos, she was pregnant, the baby was running around, the translator had no idea what the genetic counselor was talking about. There was a chasm right there. There was all the information, no comprehension, and we're talking about a situation where you don't even need these folks to do anything, you know, to read a text message, nothing. You just need them to understand, and it was not there. And that's when I started doing medical decision-making work. So a lot of what I do is really to explore the degree to which patients comprehend information on cancer, on Alzheimer's, how are these conversations being carried out, but also just with written communication, with stuff that the National Cancer Institute sends out. Do patients understand what is being spoken about? So this is, when I had spoken to Arlen previously, he was talking to me about patient behavioral change. I said, that's like the 4th floor of the building. The ground floor for me is comprehension, and we can't just assume that people are getting it. Most of the time they are not getting it, especially in a medical context. They are freaked out, or they're just inundated with information. And you know, I was just going over conversation transcripts from a large study that was in New England Journal of Medicine and JAMA, funded by the NIH for about 13 years, and I'm not going to tell you which one, but I'm reading the transcripts of the conversations, and when I give a PowerPoint presentation, I say, well, they're told this and this and this and this and that, and people in the audience start to laugh because they know that the patient walked out not understanding. So that's comprehension. Then there's the whole aspect of motivation, and you're absolutely right, Nam, what you were saying about apps. The technology is there, and I think Arlen spoke about it as well. The technology is there, it can be terrific, but what we need is for people to use it, to actually adopt it, to have it make a difference in their life in a sustainable manner. So this is what my work is about. This is what I would love to help you folks with.
So there's been a lot of talk about gaming theory. So you know, the average person isn't going to do it just because it's good for them. You got to cajole them. You got to make a game out of it. You got to do something. So is that really smoke, or how does that factor into what you guys are doing? Is that, because all you hear now is technology, gaming theory, health. Is that just another hype, or what is that?
No, I mean, I think there's some reality to it. I think you have to look at the different, context points of what you're going after. I think the first thing that we're doing in Text for Health is really just taking the basic information that's traditionally contained in healthcare pamphlets, that's contained on the materials that are on the wall, and just getting it in front of people in a form that we're used to. We've created this headline-used, Twitter-based society. People don't read things over a page or two. I mean, if you're a Medicaid patient or you're indigent care level, you're not going to sit down and read this large pamphlet. You're not going to go to WebMD and do this research yourself. So how do we put bits and pieces of information in front of you in a way that you're going to consume it, because you're consuming text messages all the time. So that's phase one. And then when we talk about trying to drive additional change, I think absolutely there's going to have to be some component of either game or social component to it, to get your family involved, to get your friends involved, to help push you along. I think that, personally, I think there's a long way to go. I think there's a lot of time to be had before those things come into play, at least on our platform. I think some of the basic building blocks of just getting some educational material out there right now is what we're focused on.
Excuse me, what I'm hearing so far is there's talk about behavior at the patient level. You know, there's talk about big data and what can be used with this big data to change provider behavior in the interaction with the patient, and all of that drives better clinical outcomes, and it drives better financial outcomes. So, I mean, that's really the ecosystem that everybody's trying to operate in, and there's all these people working at it, and everybody wants a piece of it, and everyone says, if only.
Yeah, I think Arlen got it right. It's wild, wild west out there. There's so many different efforts underway right now that the cacophony is sometimes hard to listen to. But you've also got another population. You've got a captive health population, folks that are in trouble with the system and need behavioral modification for their own benefit as well as that of society. We also work with a company called Alcohol Monitoring Systems. 200,000 bracelets out nationwide where we're monitoring patients in the field every 30 minutes, 24/7, to determine if they're drinking alcohol or not, yes or no. Historically, that data is being fed to law enforcement folks for probation, incarceration, etc. And we're now working with AMS to move that over to healthcare to enhance the treatment and recovery process for folks that are in recovery nationwide, worldwide. And what we're learning from that process is what can happen when you force people to behave a certain way versus when you incent them to behave a certain way. And their behaviors are radically different in both of those environments. So as you begin to learn how folks respond to that behavioral modification, I think that's really where we're going to start to see some real change and real opportunity from an entrepreneurial position.
I think we need to look at those, take a step back and look at the environment that we're in, right? We got all these apps running around. There are, what, 500,000 for the iPhone, and every day there's a new medical app coming out. So how do we have impact of these? What's the disruptive piece of this that's going to pull this all together at some point to have some kind of algorithm that actually helps us track what's really going on? Because while we have this proliferation of apps, at the same time we have an acute increase in obesity, an acute increase in high blood pressure, diabetes, all of these things that contribute to, in the long term, comorbidity disasters for patients long term. So what is the disruptive technology that comes in and says, boom, we're going to put this all together in a piece that finally has, as Arlen was saying earlier, what's the outcome, what's the impact, how do we begin to break this chain of consumers taking responsibility, docs being involved in that patient relationship, right? But at the same time really affecting the outcomes. And right now it looks like we're doing this rather than doing this.
Well, Larry, let's throw that question out to the audience. I think that's a great one. What could be that disruptive technology that brings it together?
And I would add another piece to the question is, what's the business model? Because if just ask Groupon and ask Facebook, what's their mobile business model? And I don't see the business model in healthcare for mobile health. So I'd ask the CEOs of the audience, what's the business model? How are you going to make money doing this? And what's the incentive to use it?
Thoughts?
I have a thought, but it's a bit of a question. I think in mobility, we forget that there was a web component to this since 1995, right? And so some of this is much more like my computer than it's ever been, right? So I think some of the discussion has to go back all the way to why hasn't some of these things happened already? Because this isn't all that different than my desktop. And so the question I look at is, what's the inflection point between being mobile or having a small screen or my location? That has to be an element. If we're going to talk mobile, it has to talk about these devices as the change, because all of it's been available. There's been ways to have communication with patients and access information and build big data for a long time. So I struggle with, if you're going to get an inflection point, it comes down to actual devices and the way that information is presented on these or how they're used, as opposed to the problem set, which is the same as it's always been. And I struggle with that.
There's a new book out on change and habits, and the gist of it is, when we look at habits, it really starts with what's the timing of it, what's the ritual, and what's the reward. And I think, with mobility, I think that ties into creating better habits, whereas when you're tied to a desktop, that doesn't exist. And it goes back to, the behavior is, I don't know. I mean, I'd be interested in what the.
Well, as a doctor, my world is, I don't use one of those in the hospital. And why? BYOD issues, you know, bring your own device and security and iPhones and hacking and HIPAA and blah, blah, blah. I hate that thing as far as inputting data. And it's okay to read websites and the front page of the New York Times, but if I have to get stuff about the patient, it's a pain in the ass. It just doesn't help. I mean, it's just, then I gotta carry it around. And then where do I put it? Now, some clever guy came up with a white coat with a pocket big enough for an iPad, which I thought was a pretty good idea. But I'm not gonna schlep that thing around the hospital, and then I'm gonna lose it, and then I'm gonna get yelled at because there's 18,000 patient records and somebody's hacking it in a Starbucks and all that. So what I'm saying is that to get doctors to kind of adapt, and the last I heard, 75% of doctors, if they have electronic medical record systems, input it on a desktop, not on a mobile device. Why? They don't make choice. For example, I staff clinics at the VA, and I've worked at other places, but so yesterday I was in the clinic and I'm watching our residents. He sat in front of the computer for 15 minutes before the patient actually came into the room. Why? To access the information and to understand, because there are no paper records at the VA. The only way you can tell why the patient is coming to see you is on the computer. So he's typing all this stuff and downloading screens, and I hate the VA computer record system. It's supposedly kind of like the hallmark of a great closed-loop system, but I hate it. And you have to sit there in front of it, and then after you see the patient, which takes 10 minutes, then you're doing another 10 minutes in front of the computer. So I figure half an hour visit, 20 minutes in front of the computer, 10 minutes in front of the patient. It just doesn't make sense.
Pam, did you have a question?
Well, it was back to when, and this is going to be a shift, when Nim was speaking and talking about text messaging. One of my questions when we look at information is generational habits. You know, we look at baby boomers as a large part of our population. They grew up with certain technology habits and are shifting. Then we have, you know, Generation Y, and they're all running around using cell phones, not iPhones. You know, I just wonder what your thought is as far as being able to reach those different groups.
Yeah, I mean, you know, again, it's the most ubiquitous form. It's not going to reach everybody. I think what's interesting is baby boomers reluctantly got pulled into text messaging from their Gen Y kids and you know, relatives, and so I think you're seeing this adoption pattern slowly moving every day to the older generations using it. What I think is interesting is you can look at indigent care, and where I think there's real opportunity in the Medicaid population for education. 86%, PwC did a report, 86% of Medicaid patients text message frequently, right? I mean, it's really kind of inverse. The lower you are in the economic strata, the more likely you are to rely on your mobile phone as your only device for communication, right? You can have unlimited text messaging, you can use it all the time. And so I think about that as far as how we can have some reach. And I think it is a little bit interesting from my perspective of a tie-in back to that original question. I think that the inflection point is still probably, you know, in healthcare it's always lagging, and so it's probably somewhere between 5 to 10 years away. And I think that inflection point comes from the consumer demand side of the equation, right? I think right now there's a struggle. I mean, you hear about the younger consumers and the younger generations wanting this stuff digitized. The older generations aren't necessarily wanting to digitize it in the hospital and the healthcare system, and so these things are coming together. I don't know if you guys saw last week, it's a little related, but everything that happened on Twitter with Aetna and the cancer patient, I mean, that's a prime example about what's kind of going on. I mean, this cancer patient hit their maximum allowed benefit payment, which is about $300,000. Aetna said they weren't going to, I think it was a student at Stanford, Aetna said they weren't going to cover it anymore. He took to Twitter, you know, went everywhere with it, and then the Aetna CEO from his personal Twitter account went and told the patient, okay, we'll cover your costs, right? I mean, it became this huge PR nightmare. And you know, again, but you know, one of the examples of things that we talk about leveraging the platform for patient communication is just patient satisfaction. If they would have been able to touch base with that patient initially to find out some of the outcomes, again, I'm going to advocate text messaging as a one-to-one communication platform. But if you've been able to do that, then you think about this shift from they're not just a patient, but they're a customer, right? And so how do you think about leveraging technology going forward, mobile in particular, because it's always on the patient as you know, the customer interaction, customer care component.
And I would add that I think the inflection point is going to become even more critical as access becomes an issue to these guys, the docs who are providing care. So if in fact the doctor shortage becomes as acute as predicted, then you're going to have a change in this digital world, because people are going to be interacting with their healthcare providers. May not be the doctor, maybe a PA, maybe an NP, maybe whoever, but they're going to be interacting with them in a much more digital world. And so as this shortage becomes more and more acute, depending on the future of the Affordable Care Act, we won't go into that, but that's going to play into the supply and demand curve about physicians. And access, I think, is going to drive digital health even to a higher level.
What we're beginning to learn is that the inflection point to us will be when technology facilitates the relationship. So Arlen is comfortable talking to his patient and interacting with his patient both face-to-face and digitally. And the technology enhances and supports that communication on both sides. We're seeing this in some of our client sites where psychiatrists are working with individuals. And prior to technology's introduction, the relationship has been autocratic and punitive. And now that the technology is in place, the behavior is substantiated, and the relationship between the clinician and the patient is much more collaborative. Yes, I'm complying. Yes, I'm interacting and following your guidance, or no, I'm not, and I really have a problem with some of the advice you've given me. Right. You've got a much more interactive relationship there that as technology really begins to hone in on that relationship and take hold, I think we'll see it explode.
Well, excuse me. You had mentioned, Larry, about it going like this.
Right.
You know, this, and you're talking about technology, and I keep thinking about data. I mean, is it the technology's getting a handle on the data, and that's what's that inflection point? I mean, so what comes?
I think it's as simple as the human interface. How does it look? How does it feel? How does the technology feel to me in terms of my communicating with Arlen? If I'm in Israel and I need some advice on an orthopedic procedure and I need to talk to Arlen, how do I connect with him? What does that conversation look like? How comfortable am I with that? And if that process is seamless for both Arlen and I as a consumer, I think we'll start to see demand.
Let's take some questions from the audience.
In following up with Arlen's comments about workflow, the impact on workflow, there are two topics that I deal with in dealing with physicians. One is getting reimbursed. You know, using technology is a major disruption to their day, and Arlen articulated, you know, the discomfort he has. So until we build a compensation model that takes into account the time spent, and as a corollary to that is the whole idea of technology obsolescence. The fact that most CIOs, as they're implementing a system, by the time it actually gets into operation, it's already a dated system. So with all these apps coming and all the innovations that are evolving through the technology community, we have this adoption issue of like, I'm just now getting comfortable with this device and this app, and now you want to change it on me, and you want to evolve it. And there's just such a rush, you know, it's Moore's law of doubling the capacity and the capability of the technology, so that there's a constant need for adoption, re-adopting, that's not compensated for. And doctors are having to spend a fair amount of time. Some of the more progressive entities are actually compensating doctors for the time they spend in training to use the equipment, but it still isn't looking at the metric of how much of my time is actually contributing to the overall improvement. And I might take a little exception with Arlen's idea that, you know, the data and the technology aren't useful, because from a population health management standpoint, if all the doctors are contributing to a unified database, there is a way for us to identify particular trends, especially things like I'm doing in mental health areas. But the idea is that we have to give doctors reimbursement or some other incentive to utilize this technology and give it some, time to gestate, because if we're constantly updating and new technology, it's very difficult for them to absorb, and not only for them, but for the public too. So
My point was the data's not useful, the information is.
But that takes a whole level of...
If you drown me in data,
right.
it's worthless. I can't sift through that given the supply and demand. You got 15 people sitting in a waiting room. I can't sift through every single entry in an electronic medical record to take care of someone. With my experience, I can probably tell you what's wrong with you in the first 30 seconds. And most doctors can, who are experienced. There are other doctors sitting in the room. If you've done this long enough, you kind of know what's going on and what to do. The rest of the time is noise. We need to figure out how to filter out the noise so that I can see you efficiently.
Yeah.
Now, do you think that consumer education, I guess you could say, educating the patient on the micro and macro cost of healthcare, so you come into the doctor because your throat hurts, then that can easily be prevented elsewhere. Do you see as a doctor any way that you can provide like education through technology that for preventative care, and the true cost for a doctor, so they see, hey, I shouldn't go to the doctor, it's costing the doctor not only time quantified, but also the cost associated with it?
Who's that question for?
That was just for the panel in general.
I'll let somebody else talk.
I don't think that the patient cares what it's costing the doctor, right? I mean, I think you have to put it back in your own pocket. If there's some basic way to say, if you have a deductible or there's some other kind of component that's going to cost you, that could be interesting. But and consumers don't care. They don't care what the doctors.
So how do you get them to care?
They're not going to. I mean, why would you? To be honest with you, why would you care about what Arlen's economics are? I mean, you care about your own economics. At the end of the day, that's what everybody does. That's human behavior.
Separately, you don't care about the app manufacturer's cost structure either. From a business standpoint, what app builders are seeing in the marketplace today is a reduction in the price they can charge for an app and the increase in the cost of developing an app. Because there's so many different OSs out there that have to be contended with, that the cost of developing those apps is increasing exponentially. So there's a business metric now in place that's going to force consolidation, and we're going to see larger businesses consolidate and bring more of these in to manage that cost structure. And consumers aren't necessarily interested in how all that works. What they're interested in is, can I pay the lowest cost possible per transaction to get what I need out of this device, this technology, this conversation?
I want to go back to your question because I think it was a good one. So, without being too political here, I think we've got a public policy issue about private healthcare versus public healthcare. If, in fact, you're providing all of these services in a public healthcare environment and nobody has any responsibility or, frankly, any risk, what are they going to do? They're going to overuse the system. They're going to go when they need to go. On the other hand, on the private side, as we design benefit plans where patients have a higher and higher out-of-pocket cost to them, they do make decisions, and they do look at what is the benefit that I need to go. If I have a cold, if I have a sore throat, do I just wait it out for 3 days and I'm probably going to get better anyway, right? So do I go make that visit or not? So there's a patient responsibility piece to this, but there's also a benefit design to this, and where we go as a country in terms of the number of people in the public healthcare ecosystem as opposed to the private side is going to drive a lot of those issues.
So one follow-up from him, can consumers text back if they've received a message?
Yep.
And are you structuring that?
Yeah, so I mean, again, basic appointment confirmations, yes or no. There's other aspects that it can be used for. I mean, you start to get into the HIPAA side of the equation when I start to say, did you work out today? What were your eating habits? You can take vital statistics. I mean, one of the things that you can use the platform for, and I think one of the things that's interesting in the current healthcare environment is the interaction takes place, in the office, and then it goes away, right? And so one of the ways we envision the system being used is to have periodic checks, right? The ability to interact with that doctor almost in an automated manner, have you been exercising? Have you been eating the right diet? Are there vital statistics that you can take from that? Again, very simple. I mean, I get a text message, I just reply with something. I don't have to open up an app. It's really easy to do. And then there's some data points. And so now when Arlen's looking at that chart, and it's been 6 months since I come in, you know, what happens is you come in, you open the door, how you been, you know, and I tell you, all I can remember is what happened the last day. I don't know what happened 5 months ago, and so there's some aspects of getting that data.
I think the business opportunity is, if you look at brick and mortar, just take Barnes & Noble, 15 years ago. So brick and mortar stores, everything has to be done brick and mortar face-to-face. Add an e-commerce component. Now you have both brick and mortar, e-commerce component, catalog, online, whatever. All of these distribution mechanisms are integrated. So now fast forward to healthcare. So now 98% of healthcare, I'm just picking this number, 98% of healthcare is face-to-face. But we need to create an online presence, non-face-to-face online care that Bob said supplements the face-to-face initial physician-patient interaction. The same holds true with telemedicine. Most people now have come to the conclusion that just seeing a doctor initially, the initial doctor-patient relationship on telemedicine, in some instances works, but in a lot of instances it doesn't. But it seems to work better when it's a supplement to an existing online face-to-face relationship. You've already established the relationship. I just need to do whatever I need to do in your home at 2 in the morning in your pajamas, or texting or whatever. So I guess the opportunity is, how do we create what I would call a hybrid care model that is face-to-face and non-face-to-face, online care, brick and mortar, with a business model that's sustainable? And that's the challenge. I also think that's where the great opportunity is. And if you can fit into that space as a business, then I think that's where the action is.
I've been living in a very video-centric world, and anytime somebody has to repeat something 3 or 4 times, you know, we make a video of it. And it's something that, to me, I think it can be very well utilized. When you're seeing a patient and you say, hey, I recognize this in 30 seconds, but yet that patient still wants 45 minutes or an hour of your time to feel like they got value. And yet you can have a follow-up of, boop, here's that email, watch this, 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 and this. It's the same things, you know, but you have data, you have hitting every type of brain type that's in there. You have all your experts. You turn the doctors into rock stars as well. And
the other problem is, if I tell you you have cancer, anything I say after that word, you don't hear.
Absolutely.
It's over. Game over. I could sit there with you and 6 patient, you know, your relatives, and I can talk to them blue in the face for an hour. You won't hear a thing I said after I say you have cancer. So I got to bring you back, and I got to bring you back, and I got to bring you back. So there's a way to provide that information, because